Hello, everyone. Welcome to the first annual meeting of Common Sense Oncology. Yay! I have waited a long time to say this. I want to say it again. Welcome to the first annual meeting of Common Sense Oncology. uh, Hello, everyone. I'm Dr. Bishal Gyawali, medical oncologist from Nepal, now working in Queen's University, Kingston, Canada, as an associate professor of oncology and a co-lead of Common Sense Oncology movement. On behalf of Common Sense Oncology team, I warmly thank you all for making it to Montreal this year. It must have been a long distance from where you live. We have members from all over the world. So thank you so much and a warm welcome to you in this Canadian, supposedly early summer, but it still feels cold, Montreal. Thank you very much. Welcome. What started as a vague idea several years ago, uh, after lots and lots of, you know, torturing ourselves about what are we even doing? Should we even do this? It is a crazy idea, but all good ideas are crazy. So is it a good idea? And after all the debate of several years, several months, we started as a unit last year, as you all know. And the response that we have received so far has been amazing. And we are so overwhelmed by that response. So thank you very much, everyone who has contributed to whatever success that Common Sense Oncology has had in this last year. So thank you very much again. And special thanks to all the founding members who gathered last year and took Common Sense Oncology to where it is today. But a warm welcome to some new members who have joined us from this year. So thank you very much. And also we are starting with this open plenary session, which is open to all the members who have registered through our website for this session. And we have received an overwhelming response. We have received more than 500 registrations. We have received thousands of membership applications from all over the world. So a big, big thank you to all the members from all over the world who, despite some of them having reservations that, okay, this is like, why can't we be actively involved? We also want to come to Montreal. And again, we had to make some difficult decisions because we are still in the planning phase. We are still in this infancy phase where we still need to plan properly. And sometimes we need to limit ourselves to a limited number of people, but the response that we have received from people all over the world, that is what keeps us going forward. So thank you very much, especially to all of you who have joined us for this open plenary session by Zoom from all over the world. So thank you very much. And I would like to welcome again the members who are here, who have come all the way to Montreal to spend these 3 days with us in brainstorming how Common Sense Oncology should be moving forward. And a warm welcome to everyone who has joined us by online today to listen to what our plenary speakers have to say, but also because of your interest in Common Sense Oncology movement. And I'm confident that in these 3 days, we'll be discussing about how to create more and more opportunities for everyone to get more involved with our movement. So stay tuned for that. And Dr. Booth will be talking about what Common Sense Oncology has achieved in this last year, what we have done in this last year, and what we are planning to do in the future. But before that, among all the accomplishments or initiatives that we have taken, we are especially proud of partnering with patients and getting patient partnered in this initiative since our early inception. And one of our goals was to at least spread the message, spread the awareness so that this type of common sense oncology is thought of as an important mainstream initiative rather than a fringe voice. So building that awareness is important, and our media people are quite crucial in that. And we have received wonderful support from media people actually all over the world in this initiative. But I want to showcase one particular example from the Canadian broadcasting company, CBC, which is equivalent of CNN in US or BBC in UK, I guess. So CBC did a nice profile on CSO, both in newspaper format, but also in the video format and in TV. They broadcasted it at the national prime time, in which they showcase the story of CSO and why it is important from the patient's perspective as well. And I think it is worth showing that video, at least a clip of that video to begin this session, because it tells the perspective of CSO from patient side and also from physician side. And I think that would be a good way to let all the audience who have joined today to see where CSO is coming from. So I'd like to start with that video.
And he was literally dying before our eyes.
With weeks, months, or years to live, many patients seek out new cancer drugs, hoping they'll help. But some doctors argue many new drugs offer few benefits while sacrificing the quality of life patients have left.
And the unfortunate reality is some of our treatments don't even help people live long.
I feel fortunate. I've had a great life, good kids, family. So
we feel quite blessed through this at the same time.
Tom Somerville was diagnosed with colon cancer in 2021, and it spread. He underwent 6 exhausting months of chemotherapy before asking his doctor for a break.
He said, you can take off as much as you want. And so we did that, and we had a really good summer.
Including a trip to British Columbia, making new memories along the way. Eventually, with the support of his family, Tom decided to stop treatments.
There wasn't a huge chance of things getting much better. And I think if you come to terms with that, it's a lot easier then to sort of enjoy the rest of the life you do have.
Tom's decision not to treat his end-stage cancer is personal. It's a choice that many people don't often talk about. But doctors at this hospital in Kingston are trying to open up that conversation. They call it common sense oncology. So let's find out what it means.
When we arrive, Dr. Christopher Booth is checking in on patients receiving chemotherapy. A woman who's aware her cancer is terminal says family members are asking her questions.
Is this chemo going to get rid of everything?
Yeah, it's a really good question. Okay, so you might remember we talked about that at the beginning. Yes. Okay, so the chemotherapy will not make the cancer go away. Okay, we can't get rid of it. The goal here is to try to shrink it down and control it for a period of time to help you feel better. Okay, so the pain and the symptoms are dissipated.
Interventions or treatments like chemotherapy can extend survival. A Canadian study looking at potentially inappropriate interventions found around 40% of terminally ill cancer patients were still receiving at least one intervention in their last 30 days of life. Booth stresses if someone has 6 months or a year to live, how they spend every day matters.
And if they're going to spend every day, every Monday in the chemotherapy unit, they're probably going to want to know that treatment's going to really help them. I think everyone would agree that a treatment helps people live for extra years or many extra months is probably very helpful. But if a treatment helps someone live for an extra few weeks or an extra couple months with a lot of side effects and a lot of time, different patients will have different perspectives on that.
To understand better how drug approvals work, we walked over to Queen's University to meet Dr. Elizabeth Eisenhower.
And it's a good thing we are having so much interest in finding novel therapeutics for cancer. But my goodness, let's find the answers that matter to patients too. 83% of all clinical
in cancer research circles and beyond, Dr. Eisenhower is a big deal. Now retired, she ran over 170 drug trials in Canada, the US, and Europe. Eisenhower says in the 1980s, scientists made an estimate. If a cancer drug could shrink a tumor by 20%, it may be of interest. But what started as a general value became an endpoint or goal for drug companies. Problem is, shrinking tumors doesn't necessarily help patients live longer or better lives.
I'm hoping the common sense oncology movement will do, not just for academics doing trials, but for pharma and for regulators, is make them want to recalibrate what it is they're looking for in those new drugs.
Not all trials are bad. And we can.
Dr. Bishal Gyawali has treated cancer patients in Nepal, Japan, and the US. Now in Canada, he too is firmly pushing for change.
Sometimes, like Canadian patients, when they
read these things in news and know that, okay, there are like 3 other drugs in US, but we don't have access to it in Canada. I wish I was in US, but those are drugs that really do not provide much value to the patients.
My husband would have done anything. He was not willing to go ever, and he would have had any treatment they gave him because that's where his hope was.
Rachel Coven's husband Ken was diagnosed in his late 40s. A father and avid runner, he treated cancer like a battle. He underwent painful brain radiation in the weeks before he died. Coven doesn't begrudge any of his decisions, but feels families should ask more questions of doctors, like how much time does this treatment offer, and what are the real costs and benefits for patients.
Not having treatment isn't giving up. Sometimes by having treatment, you're giving up. You're giving up time with your family. You're giving up a quality of life necessarily for something that you're not trading off any extra days.
For myself, if I was clinging on to hope all the time, it would make the last couple of years very difficult because I would see myself getting sicker.
Hope can be a tricky thing. For the Somervilles, it's not gone. It now lives in every moment of every day.
But simple things like just walking down to the pond, being out with Catherine, taking little drives in the car when it's a nice sunny day, just the companionship.
An eye glance, that you hold each other in your eyes, you really, and a lot more hugs because you appreciate that moment and you want to take it all in. And those are the simple things that really are not so simple. You realize they're the important things.
Thank you very much, everyone. Next, I'd like to invite someone who needs no introduction. He's the co-founder, co-leader of Common Sense Oncology Movement. He's the person behind making everything happen. And he's someone who, I don't know how to introduce. He's my brother, my mentor, my colleague, my dear friend. One of the privileges of my professional life after moving in Canada has been the ability to call this to Chris, my brother, my friend, my mentor, my colleague, my partner in crime. So Professor Chris Booth, who, as you all know, is the mastermind behind making everything happen at Common Sense Oncology. So I'd like to request him to give a talk before starting the plenary session to talk about what CSO has done in this last year since our inception, and to share some of his vision about CSO 1 year later, and to give you a background on our accomplishments and future opportunities. So welcome, Dr. Booth.
Great, thank you, Bishal, and thank you all for not only being here in person, but for everything that's happened over the last year. It's been quite a remarkable year, and it all started really exactly a year ago with the people from this room in a planning meeting in a small university town in the countryside of Canada. And it's amazing to see where that energy has gone over the last year. So it's very exciting to be here today with everyone. And I guess at the outset, I also want to deeply acknowledge and thank Rachel and Tom, and the other patients and advocates who have inspired this work, and certainly, the words that we hear from them every day in clinic, and that Rachel and Tom and their family shared with us in that video that we just watched, I think is really what keeps all of us motivated to make things better for patients and their families. This is my usual disclosure slide. I have no relationships with pharma, but I always start with an intellectual and emotional disclosure, which is that some of the work that we do in Common Sense Oncology, it celebrates things that work well, but some of it is to be self-critical, but in a constructive way. And so before I, pass any criticism on our field, which comes from, the best meeting place, I just want to state that all of this, for all of us here in the room as oncologists, academics, investigators, clinicians, patient advocates, editors, this comes from the deep privilege of working with people and their families who have cancer. And just to remember that, the essence of oncology is really the art of the craft, which is compassion and communication. It sometimes has to do with treatments as well. And that's some of the work that we do as a group, which is to really promote and advocate for those treatments that everyone should have access to, but also to have some self-humility and introspection about some of the treatments that perhaps don't offer as large benefits as we think. So I think these are the domains, at least a short list of some of them, that bring all of us here into this room and inspire all of us to do the work that we do. Access to care, equity and health justice, affordability, quality of care, outcomes, and patient-centeredness. And I think it's important to start with this as a grounding exercise, because I think some of the times when our field, as well-meaning as it is, has gone off the rails a little bit, it's perhaps because we've lost sight of some of these core domains which really matter. Over the next 10 or 15 minutes, I'm going to go through a story about CSO. I'm going to start with 4 paradoxes, which I think illustrate some of the challenges that this group 1 year ago set out to work towards solutions. We're going to talk about the launching of CSO. We're going to look back over what's happened in year 1 of this initiative, and then some brief thoughts about the future. But obviously, the next 3 days is really all about planning for the future of this initiative. There's many paradoxes in global cancer care. Richard Sullivan and I plan to write a book one day about this because there's dozens or hundreds, but here's a few of them. The cancer medicine paradox is a scenario in which there is substantial overutilization of marginal, toxic, and expensive medicines in most health systems of the world, especially near the end of life. While at the same time, those treatments that we have that truly make a big difference in the lives of our patients remain unavailable and are unaffordable to most people globally. I call this the NGS and communication paradox. I don't know much about NGS, but what I do know is that in the last couple decades, there's been an explosion in fundamental knowledge of what drives cancer at the biological level. We know more and more about people's tumors, but at the same time, we failed in the art of oncology, which is the communication. And so this is work, famous piece of work by Jane Weeks decades ago, and then an updated similar study more recently that shows that, a majority of patients who have incurable cancer still think that their treatment is being delivered with curative intent. And so we know very, very much about some aspects of what we're doing in our field, but there's other parts of our field where we can do a much better job. This is the 3-bucket paradox, and I think this reflects an external communication failure on the part of medical oncologists and other oncologists as a field, which is that if you read the newspapers, it's not hard to imagine why patients, families, and the public and policymakers think that every cancer treatment we have is transformative, a game changer, a breakthrough. And that comes a little bit from within our own community. And I think we all recognize that there's actually 3 buckets of cancer treatments. The red bucket are those treatments which are truly transformative and cure patients or add many, many years of life. They're just remarkable advances in medical care. The green buckets are those treatments which also are very, very good. They're not transformative, but I think most patients, and maybe us as maybe future patients, would be very interested in these treatments that offer substantial benefits. The problem is that the blue bucket is the one that's not really talked about in a sense, but a lot of the new treatments fall into this blue bucket. And these are treatments that have very small benefits. Many of them, there's either uncertainty or no proven evidence they help people live longer, better lives. They often shrink tumors on a CAT scan. But this is, of course, comes with a lot of toxicity for our patients. And I think this is a bucket that has driven a lot of the concerns that led to common sense oncology. And the last paradox I want to touch on, which is an important one in my clinical practice. I have the privilege of looking after people with GI cancer, and many of them have advanced incurable disease. I call this the last 6 months of life paradox. And this is a scenario that plays out in many hospitals around the world every day, which is that we have health systems set up such that if I'm seeing a patient with an incurable solid tumor who has progressed on therapy, the health system in many countries is set up for me to be able to prescribe a very expensive drug that in the clinical trial did not improve overall survival. There might have been a gain in progression-free survival of a few months, but we know it has very real side effects and time toxicity for that patient. And I can actually fairly easily prescribe that, and that's pretty standard in many parts of the world. But at the same time, for that very patient who might live at home by themselves and be isolated, sick, and vulnerable, it's almost impossible for us to mobilize the supports with psychosocial care, palliative care, nursing, and home supports to allow that patient to have meaning, dignity, and quality near the end of their life. And I think all of us, as future patients of some form or other in the health system, would recognize that we really need to ensure that we provide that latter. I've been working with people with cancer now for 20 years, but over that time and even leading up to that time, we've had remarkable successes in our field. And I think it's worth recognizing those and celebrating those before we talk about some of the things that we can do better. We've had an explosion in the knowledge of cancer biology. We do truly have some remarkable treatments that are out of a movie, really. 10 or 20 years ago, we never would have imagined some of these things. Some cancers are actually, the outcomes are getting much, much better. We have a long way to go on this, but we are, compared to 20 years ago, more intentionally and thoughtfully engaging the patient voice in everything that we do. I think there's growing attention to the other critical elements of holistic cancer care, which is the psychosocial domains, palliative care. And then oncology, I think, is now, again, we still have work to do, but it's recognized as an issue of global health and health justice. And so I think these are some of the successes that have come over the last 20 years. But we have some challenges. And I imagine this, I call this the cancer value crisis, which is a convergence of at least 5 factors. And, in this room today, there's experts from all over the world who have expertise in these things. And we have a very powerful tool, the randomized controlled trial, which is the most important way to advance care for patients with cancer, and when done properly, can transform treatment landscapes. But there can be some problems with clinical trials that we're learning more and more about. We have an explosion of endpoints that are of uncertain benefit to patients. And in fact, some surrogate endpoints are very, very appropriate to use. Some surrogate endpoints, there's maybe nuance and one could make a case for using them. There's some cases maybe where surrogate endpoints are perhaps not appropriate to use, but we're also seeing surrogates of surrogates and more surrogates. And I think, at some point as a field, we have to just, think about how distant are we willing to get from what really matters to patients. So this is a conversation that our community needs to have. We have treatments with very large effect sizes, but in aggregate, many of them have very, very small effect sizes. We have a staggering and unjustified price problem when it comes to cancer medicines and many other technologies. And then fundamentally, we have a level of a breakdown of communication, both sometimes at the bedside between doctor and patient, but more broadly within our community and with the public. And so it was, in recognition of the things that we do well, but the things that we can do better, that led to, a year ago, this group gathering in Kingston to talk about, let's do something about it. And that led to the launch of Common Sense Oncology. And, some of this started, there's people have been doing this for much longer than me and many of us in the room. And so this was taking ideas that have been circulating for a while and saying, it's time to do something about this. And so this was a paper that my little brother and I wrote, talking about, and it was tongue in cheek, the history of this common sense term. But anyhow, we said, we can do better. We need to do better about how we treat patients, how we do research, how we educate, how we deliver models of care. And, we had several conversations about this. And one evening, after a beer, Bishal said we should launch the Society for Common Sense Oncology. And I initially said, Bishal, that's a crazy idea. But like many of Bishal's ideas, they're actually quite good. And we thought about that, and we talked with many people here in the room, and people said, yes, let's get together and have a conversation about how to do better. But I do want to say that while Bishal exhibits common sense in his professional life, in his personal life, there are moments where he lacks common sense, and perhaps his older brother does too. So Bishal and his family moved to Canada via the United States from Nepal. They did not have a lot of experience either swimming or walking on frozen water. And within literally his first week that he arrived, it was springtime, and the Booth family told the Gyawali family, you need to come with us to visit our friend's farm. We're going to go for a hike in the woods, and we're going to go ice fishing. And this was Bishal ice fishing. He'd been in Canada for about 48 hours. And just to watch him and his family walk on frozen water with great trepidation, and he actually caught a fish. And you can see that that's like a really big fish. And so after that, he thinks fishing is very easy. But I'm not so sure that it was wise, because it was March and it was starting to break up, and the ice was starting to break up. So this might be an example just to remind us that we all have in our personal lives rooms for improvement in our common sense decision making. But this is the cast of characters that came together a year ago to have a conversation about what do we want to do about some of these challenges. And we had 3 very vigorous days of discussion and debate. I'm sure people remember, I will never forget day 1. and everyone had gone off to the pub, and I was sitting in the lobby by myself thinking, what kind of can of worms have we just opened? And it's because we brought together about 30 people with a collective IQ of 100 billion and passion off the chart. And we said, what do you think the problems are and we should do about it? And chaos ensued, but we almost had to get that out on day one. And then things really came together on day 2 and day 3. And we're going to reflect a little bit about that and also talk about, you know, where things have gone since. So why did this group of people decide to launch an initiative to change things? It comes from a deep place of caring for patients and their families and for the health system that we think we can do better. We have a strong belief that patients deserve better than this. I think there's also restlessness and an unwillingness to remain silent on this problem and to see these things perpetuate in health systems around the world. We also were very mindful of the fact that we didn't want to just be critics. We wanted to move beyond criticism and be solution focused. We wanted to set an example for the next generation in our field and really to socialize these ideas and to create a space where we can talk about these things honestly. We can reflect, we can have some self-humility about what's not working so well in our field, and we can affect change. And one of the lectures I gave many years ago, the title of it was "The Emperor Has No Clothes." And I think that this you know, ancient fable pertains a little bit to the story. And this is the emperor walking through town, apparently in a, you know, lovely gown, but he's just wearing his underwear, and everyone's telling him how lovely his gown is, until, you know, a young child points out the obvious, which is, you know, the emperor is wearing underpants. And I think in some ways, the challenges that we've, you know, been very explicit in identifying with Common Sense Oncology, people have known about for a long time. And really, our community hasn't really known what to do about it. And I think this is kind of catalyzed in this moment to say, let's talk about these things because we can do better. So from that planning meeting came what's been called the Common Sense Oncology Manifesto, published in Lancet Oncology last summer, where we outlined the mission of this group is to ensure that cancer care focuses on outcomes that matter to patients. Our vision is that regardless of where people live, they have access to those cancer treatments that make a real difference in their lives. We have a series of guiding principles, and we hold each other to this in our work. We believe access to quality cancer care is a basic human right. Patient and societal needs should be driving decision-making rather than pharmaceutical profits. Patient and public involvement is essential in making policy decisions. We think it's reasonable that when a patient walks into a cancer hospital, they should be able to expect that the treatments offered to them will help them live longer and better lives. Obviously, all of this is based on truly informed and shared decision-making with patients who are at the center of all of this. Cancer treatment should be fairly priced for the benefits they deliver in the context in which they are used. Equity and access to quality care is just as important as new innovation, and health systems should prioritize that. And finally, recognizing that comprehensive patient-centered care is much more than just medicines, radiation, and surgery. We need to ensure that all of the holistic aspects of care, from prevention through end-of-life and palliative care, supportive care, are provided to patients who could benefit. We organized ourselves around 3 core pillars of work. Our mantra is outcomes that matter should drive systems and our work. And so we tackle evidence generation, evidence interpretation, and evidence communication. And around these 3 core pillars, we've had a series of 4 project teams that have done remarkable work. These project teams include oncologists, academics, other clinicians, regulators, and most importantly, patients and patient advocates. We have a team looking at how to design and report RCTs, how we can improve stakeholder engagement, how we can educate oncologists, and how we can improve communication, both at the bedside, doctor-patient communication, but also more broadly with society. And so just briefly to give an update to our broad global membership that's listening, so these teams have been very, very productive. And so the RCT project team, led by Ian Tannick and Bishal Gyawali, together with their colleagues, have come up with a guidance framework for RCTs in a CSO, using CSO principles, including concepts that overall survival and quality of life are major endpoints. A control group should be given that is standard of care. Optimal post-progression therapy is essential. Trials should be designed with a target effect size that meets at least some threshold of the benefit that's considered meaningful. Informative censoring is something that needs to be considered. The reporting and writing of the event needs to be independent of sponsors and medical writers, and that we actually, to improve communication, should have a lay abstract published in every piece that actually in plain English allows patients to understand, what does this really mean for them, moving beyond hazard ratios and p-values. What does it really mean? And we've had some early success. We've had remarkable support and conversations and buy-in from a number of major cancer organizations in our field, including the American Society of Clinical Oncology. And this is, through leadership of ASCO, have incorporated a modified version of the CSO checklist into a framework that discussants for the plenary session at ASCO annual meeting in Chicago in June are going to be asked to comment on. And I think this will improve the ability of our field to critically dissect RCTs that change practice. Our CSO engagement team, jointly led by Dr. Brooke Wilson and Dr. Manju Sengar, is undertaking mixed methods work to understand, what do oncologists think of these principles? How can we be receptive to feedback? How can we engage the community? How can we identify barriers and enablers to change and work to affect system-wide change? They're undertaking focus groups by world region. They're doing a thematic analysis of transcripts to learn how can CSO change culture, mindsets, and systems. We have an education team led by Dr. Scott Berry and Dr. Aaron Goodman that are working on a number of initiatives, including to validate a set of competencies to guide training, so the next generation of oncologists are perhaps better informed about things like critical appraisal, epidemiology, and critical thinking. They're undertaking a systematic review of curricula from around the world to work with educational leadership to deliver better training modules in these domains for the next generation, and are working with educational partners worldwide to disseminate these competencies. And the fourth project team is the Patient Priorities Group, led by Dr. Michelle Tregear from the National Breast Cancer Coalition, a leading voice and patient advocate, and Dr. Chris Jackson from New Zealand, that are undertaking a thematic analysis and the design of a patient charter, a patient bill of rights. And the CSO patient charter has been drafted with patient advocacy input and is now undergoing a global speaking and listening tour, engaging intentionally with patients and patients advocates worldwide. We've done this with groups in New Zealand, India, and the US to get feedback, to modify the charter, to ensure it reflects the views of the key stakeholders. And there's more to come here. Profile and engagement. So as Bishal alluded to, we had no idea how this would go when this launched a year ago. And I think it's fair to say it exceeded all of our wildest imaginations. It has been at times overwhelming, but also remarkably exciting to see the number of groups, people, stakeholders, and institutions around the world that have been very interested in this. Our piece in Lancet Oncology was very widely read. The media have been very, very interested parties in telling the story. We have a major session coming up at the ASCO annual meeting, educational session on common sense oncology. Members of our group have given dozens, if not hundreds, of lectures at major meetings globally. Membership is growing very, very rapidly. And we've had early engagement with key stakeholders, patient advocacy groups, regulators, trial groups, funders, oncology leaders, and policymakers. And this is just a snapshot of some of the groups that we've had formal engagement with, given lectures to, seminars, or have in the near future planned kind of co-educational or lecture materials coming. So it's been really amazing to see how diverse the response has been, both globally. So the membership comes from remarkably diverse health systems, but also the feedback that we've received. Some early successes from the project teams, the clinical trials group. Clinical trials team is already engaged with major trials groups worldwide to get input and feedback. They have a standards checklist nearly ready for publication. And as mentioned, some of this will be piloted at the plenary session at ASCO in the discussants. The education of oncologists group has almost completed a systematic review of curricula to make modifications and revisions and suggestions going forward. And we've started a very popular virtual webinar journal club for oncologists and trainees. The engagement team has done focus groups with clinicians, patient advocates around the world, and will move beyond patients and advocates to actually talk about these things with other stakeholders, trialists, funders, the pharmaceutical industry, and regulators. And the patient priorities team has come a long way with their patient charter and doing a patient advocacy listening tour. We've been able to build capacity with some early philanthropic support, including the funding for this meeting, for which we're very grateful, that comes from a patient advocate in San Diego. We've hired 2 staff, a director, managing director of Common Sense Oncology, and a research assistant. We have 2 CSO fellows joining us in July. We advertised, for a fellowship with a group that was very, very new and unheard of and had 70 applicants and chose 2 superstars to join us in July. There's major interest in expanding that 2025. That's something we're going to talk about over the next few days. And the annual meeting, of course, today in Montreal with this very engaged group. So just in closing, I think, we've reflected a bit on the last year and what is it about CSO that has resonated so well? I think some of it is timing. I think if this had been launched 10 years ago, it might have been more difficult. I think, though, that it comes down to this group is united around, this is a purpose-driven initiative. We're very clear in what we care about and how we want to get there. I think it comes from an authentic place of caring and believing that we can make things better. Every organization that thrives is based on the people. And the really fun thing about this group is the remarkable people that we get the chance to work with that bring incredible creativity, intellect, and energy to this work, a recognition we can do better, and a willingness to collaborate broadly. For those of you watching on Zoom, one of the strategic focuses of the next 3 days will be to talk about how to do a better job of engaging the membership globally. So please stay tuned. But in the meantime, you can spread the word, encourage others to join CSO. You can, I think, practice some of the principles of CSO philosophy, which I'm sure many people are already doing in clinical practice and teaching in their leadership roles and in health justice advocacy. Join CSO events with journal clubs and webinars. Encourage the next generation to think differently, and stay tuned because there is more coming. So in closing, I'm just going to paraphrase the last paragraph from our piece in Lancet Oncology from last summer, just to leave the listeners with a sense of the ethos of this group. Common sense oncology will promote interventions that measurably improve the lives of patients. We will celebrate well-conducted trials and promote effective treatments, but we will also speak up about and challenge interventions that might cause more harm than good. We seek to decrease global inequity in access to affordable, high-quality care. Improvements in the generation, interpretation, and communication of evidence will help close these gaps and move our field closer to a future in which a patient's outcome is not determined by where they live, what they can afford, or the strength of a marketing campaign. And with that, I'll close, and thank you again for being here, and I'll hand back to Bishal to introduce our keynote speakers.
Thank you very much, Dr. Booth. As you can see, we have done a lot, but miles to go before we sleep. So really looking forward to coming 3 days in which we plan our future. But for now, I have the pleasure in introducing the moderator for the plenary session series. For today, our moderator for the plenary session is Dr. Verna Vanderpuye. And Dr. Verna Vanderpuye is a senior consultant at the National Center for Radiotherapy, Oncology, and Nuclear Medicine at the Corlebu Teaching Hospital in Accra, Ghana. And she also holds a global oncology professorship at Queen's University through the Global Oncology Program. She was the recipient of the 2019 International Women Who Conquer Cancer Mentorship Award from the Conquer Cancer ASCO Foundation. And her interests are in breast, sarcoma, genitourinary, and gastrointestinal cancers. And her research interests are in managing cancer in Africa. So please give a warm applause to Dr. Verna Vanderpuye. And I'll ask Dr. Vanderpuye to introduce the speakers.
Yes. So thank you so much, Bishal, and thank you all for being here. We have lined up in the next hour 4 speakers for our plenary lectures. We start with Carolyn Taylor, who's going to talk about patient-centered oncology, essence of common sense. Carolyn is a global cancer care advocate and a founder and executive director of Global Focus on Cancer, an NGO established in 2011. And she promotes simple and effective change to help reduce the global burden of cancer. And most importantly, she likes to elevate patient voices and equity in cancer care in relation to resource and culture, which is something that we need to talk about. Then the next speaker is going to talk about CSO and global health equity. She is Dr. Manju Sengar, a professor of medical oncology at the Tata Memorial Hospital. She's a professor and department chair of medical oncology at the Tata Memorial Hospital. She had leadership roles in the National Cancer Grid of Cancer, a policy advisor to the WHO Essential Medicine List, and has broad research in access to care, health services research. Then we also have Dr. Julie Gralow, who's going to be talking about ASCO and CSO, Convergence and Collaboration. She's the Chief Medical Officer and Executive Vice President of the American Society of Clinical Oncology. She's a Professor Emeritus at the University of Washington School of Medicine, and where she directed the medical oncology programs. And she also an affiliate professor of global health. And she also founded an NGO, Women Empowerment Cancer Advocacy Network, to support cancer advocacy and education in low to middle income countries. And last but not the least, we have Dr. David Collingridge, who's going to talk about leveraging change. And he's the editor-in-chief of the Lancet Oncology since March 2022 and publishing director of the Lancet Specialty Journals. He's won several awards for projects focused on cancer control in low to middle income countries and a visiting professor of global oncology at the King's College, London. So I will start with Carolyn Taylor. We welcome you to the stage. Thank you.
Thank you all so much. Thanks to the organizers for the opportunity to present here today. Forgive me for using notes. There's a lot of slides, a lot to get to, and I don't present that much. So no one wakes up one day and declares, I'm going to be a cancer patient advocate. It's not something that one aspires to. For more than 35 years, I worked as a commercial advertising photographer, specializing in food and product photography. In 2006, I was diagnosed with ovarian and endometrial cancers. I was incredibly fortunate, diagnosed at an early stage, able to make a total recovery, but you're never really the same after a cancer diagnosis. And I felt compelled to do something to help others not as fortunate as I had been. But my skill set didn't exactly translate to helping people with cancer. So one day I got a random email from British Airways, and it was a contest offering 10 free business class flights, which ruined me for the rest of my life. It was based on a series of essays, and in those essays, I spoke from my heart about wanting to use photography to document that cancer has no borders, that regardless of race, religion, nationality, or economic status, we're all one when it comes to cancer. I hit the send button, I forgot about it for 6 months, and then one day I got that call that said I was one of the winners. So I was thrilled and completely terrified. So between March 2010 and March 2011, those 10 flights took me to 14 countries, interviewing and photographing cancer patients, survivors, caregivers, and medical professionals trying to give a global face to cancer. I saw patients and their families suffering because their needs were not being addressed. Physically overcrowded hospitals taxing not just patients, but placing an enormous burden on healthcare systems and clinicians. I quickly learned there is little equity in cancer, and that where you live, the color of your skin, your gender, and what God you believe in often determine what your outcome will be. That 70 to 80% of cancer patients in low and middle income countries were diagnosed at late stage and would die within 2 years of receiving their diagnosis. That too many patients and their families had little literacy about cancer and few resources to assist them. I saw great human tragedy, incredible resilience, and had the honor to meet inspirational people who changed my life. Harmala Gupta is one of those people. She was diagnosed with late-stage Hodgkin's lymphoma when she was studying for her PhD across the street at McGill University. When she returned to India in 1991, she, inspired by the support she received in Canada, she founded the first cancer support group for the country, Cancer Sahयोग. She quickly learned that palliative care was the most important thing that she could do and created an NGO called Can Support. They provide free home-based palliative care to the most underserved in the Delhi area. And every day she helps people in a profound way. And I had the unforgettable day spending time with one of their home care teams providing care in Delhi. So 2 people I met that day were Musty Devi and her daughter. This is Musty. She'd been diagnosed with thyroid cancer and her daughter with cervical cancer. They were living together in one room that had 2 beds, 1 plastic chair, a small shelf that held all their belongings, because when their husbands and father found out that they had cancer, they were abandoned. In Thailand, I had the privilege to meet Kunanya, and her story is unfortunately all too common in the world. She was living in a slum in Bangkok, raising her 3 grandchildren on about $6 a day. The year before, her son-in-law had died from asbestos poisoning, and her daughter was 33 and diagnosed with cervical cancer. Kunanya cared for her daughter for the 4 months and 14 days she remained alive after her diagnosis in the one-room corrugated tin shed that they called home. They didn't have money for a hospital. They often didn't have money for pain medication. It was before universal healthcare was implemented throughout Thailand. And when she felt her daughter couldn't take it anymore, she gently took her face in her hands and told her it was okay to go. Out of all the countries I visited, Vietnam surprisingly allowed me complete and total access to 3 of its oncology hospitals and patients, providing an unfiltered glimpse into the realities of cancer. The word patient has a much deeper meaning to me now. This is the waiting area in Ho Chi Minh City for oncology patients. Patients wait and they wait and they rarely complain. This is the chemotherapy waiting area at that hospital. 2 to 3 patients sharing a bed is completely normal. In Kantha, in the Mekong Delta, they set lawn chairs up where they would normally park motorbikes to accommodate the overflow of patients. People grab space anywhere they can find it. There are patients on the floor under the overflowing beds. 68% of cancer patients in Vietnam will experience financial catastrophe after a diagnosis of cancer, the highest rate in the region. Patients have to bring their own caregivers with them. The hospitals don't have the capacity to provide personalized care. I saw this both in Nepal, India, Kenya, and Tanzania, and sometimes these families are living in these stairwells or hallways for months at a time. When Rosemary O'Keel learned she had breast cancer, she considered it a death sentence and she refused all treatment. When we met in Nairobi, she was undecided about continuing her treatment. So I told her my story and she couldn't believe it because everyone she'd ever known who had had cancer had died. I was the very first cancer survivor she ever met. She also didn't know that there were such things as prosthesis or mastectomy bras. And we had brought a big duffel bag, which of course was the bag customs wanted to search. And of course it was the bag my husband had. So I took her up to my hotel room and helped fit her with a new bra and prosthesis. And the woman who was a half an hour ago defeated and ready to give up was literally singing and dancing in my hotel room with a renewed spirit to live. Sometimes, small solutions can have significant implications. When I visited Ocean Road Cancer Institute in Dar es Salaam, Tanzania, it was the only public hospital to provide chemotherapy and radiation for 49 million Tanzanians. There were 100 beds, 2 cobalt radiation machines running 24/7 when they were running, and there was a 6-month wait list. They didn't have MRI or CAT scan at the time, and there were 4 oncologists to serve the entire country. This 12-year-old boy had been diagnosed with leukemia. He had a very good prognosis. His father was with him for his first round of treatment, but for the next 6 to 8 weeks, he would remain there alone at the hospital because his dad had returned home to take care of his other children, and they lived 4 hours away. So my last British Airways flight was just over 13 years ago, but this journey was far from over. I felt compelled to do more than just document this through the lens of my camera. So I founded an NGO called Global Focus on Cancer to act as an agent of simple and effective change to help reduce the global burden of cancer. My mantra is, are your good intentions the best intentions? And we kind of use that as a guiding principle. We put patients and their families at the center of everything we do. We use evidence for program development and implementation and generate knowledge, data, and tools for adapting programs to other settings. Our programs are implemented and driven by local partners. They fit into national strategies and are embedded into healthcare systems. Just going to go over briefly a few of the things we do. So we started our work in Vietnam in 2012 with clinician-led support in the hospital setting, really trying to bridge the knowledge gap between patients and healthcare providers, improve communications, and introduce the concept of supportive care throughout the country. We looked at a model of peer support that I was introduced to when I had cancer. We've developed it into Stronger Together. We piloted it in Vietnam. We actually had a US NIH funded clinical trial that we ran there at 4 sites with breast and gynecologic cancer patients. We built a toolkit to guide the implementation of it to other settings, also other cancers, and potentially other disease platforms. We're piloting that right now in Vietnam, the US, Rwanda, and with a culturally and linguistically diverse population in Australia. Cancer Navigator is a program that looks to address health literacy and assist newly diagnosed patients and their family with navigational support through short video and infographic narratives delivered by healthcare providers and survivors. That's coupled with a resource guide for locally available food and housing and transportation services. We facilitate collaboration, networking, and capacity building through programs like our Southeast Asia Breast Cancer Symposium. This annual meeting, which began in 2016, unites global and regional experts in the field of breast cancer, including researchers, clinicians, policymakers, patients, advocates, and caregivers to improve cancer care in the region. It's become a catalyst in the creation of a regional-based coalition for women's cancers. Chris asked me to talk a bit about how I see CSO impacting advocates and patients. I have a bachelor in fine arts, so common sense, my personal experience, and hundreds of personal experiences that were shared with me form the basis of our work. So some of the systemic barriers that we have in this are access to funding and research. It's really challenging. Large NIH grants are difficult for us to obtain by ourselves because of institutional capacity constraints. Academic partnerships are challenging because, at least in the US, upwards of 60% of the funds are taken for indirects. Industry is often more navigable with less constraints, but tends to prioritize industry objectives. Okay, journal access is just horrible for us. It is really expensive. It is cost prohibitive for us to access journals and for the ability to publish the efficacy of our work. Meaningful engagement with advocates. What does that mean? What does it look like? It means different things to different stakeholders, and advocates shouldn't be included on a study or a paper merely because of the optics, but considered full and equal partners from inception through to completion, including financial compensation. And we don't have protected time. As advocates, we have our own professionalism to consider. There's a lack of competencies and professionalism in this work, and this is something that is needed to address on a broader scale to be taken seriously. This talking about prioritizing people, I really would like to acknowledge my colleague, Dr. Anna Cabanas, as she has been leading the work for GFC in this field. And this, I'm really referring to her framework. We need to reconsider how we define successful treatment. We need to empower patients to move from passive recipients to active participants. We need to shift to a more holistic, patient-centered model that considers all aspects of the patient experience, that doesn't solely focus on the biomedical aspects of it. We need to understand and prioritize services that address outcomes that are meaningful to patients and align with their values and preferences. And new ideas and tools are needed to assess patient-centered outcomes and unmet needs, ones that, again, prioritize patient-defined metrics and patient empowerment. The British Airways project opened my eyes and heart in ways I never could have imagined or hoped for. I am so very grateful for my life. As a photojournalist, I was a total failure. I became deeply involved with every person that I photographed, and it was all very personal to me. Having cancer has led me on a journey, both figuratively and literally, and on that journey, I've learned that every one of us has the ability to make a difference in the world. That if you try, your good intentions can help others in ways you never could have imagined or hoped for. If someone said to me 20 years ago, you know, you're going to have cancer, but it's going to turn out to be the opportunity of a lifetime for you, I would have said they were crazy. But for me, it's been just that. Thank you all so much.
Thank you so much, Caroline. You're doing the patient's lens, something that we don't know how to do as oncologists. Listen to the patient's story and engage in the patient's journey. So there'll be time for questions after the presentations. I'd like next to invite Manju to the podium to come and talk about CSO and global health equity.
What I'm going to do here in next 10 minutes is actually what Chris talked about and what you saw, and trying to see whether, you know, where is the common ground there, and talk about what does common sense oncology means for global health equity. The entire thing which is being talked about, all of you have heard, that common sense oncology is about ensuring that cancer care focuses on something which is important or the outcomes which are important for patients, irrespective of where they live and what is their socioeconomic background. But what's been happening, as Chris highlighted, that we are getting more and more advances in cancer care, so-called breakthrough innovation. Some are not so good, some are good breakthrough innovation. And their biggest threat is actually for the equity of cancer care. And even if you look at our intentions have been good. If you look at the sustainable development goals, health is on the top. And there are triple billion targets which are there, which talk about universal health coverage, talk about handling health emergency, health and well-being. But the problem is, or the sobering reality, as I would like to call it, is that even as of today, a significant proportion of people are not able to access essential healthcare services without getting pushed into poverty. And it's largely because of the variable health spend which individual countries are able to spend on universal health coverage. And it's more starting to see that this discrepancy is actually where you have maximum need, you have the least health spend being done. And if you look at the cancer burden, both in terms of incidence and more so in terms of mortality, the burden largely lies in these countries which are spending dismal amount of their GDPs on the health. And what it leads to mortality largely because of the poor access as well as poor quality of the care which is being delivered. However, we all get very gung-ho about cancer care. It's important to remember that many of these countries have pressing needs with for whether we talk about infectious disease, whether we talk about maternal and child health, cardiovascular disease. So we do need to be mindful, and I think the CSO is more important in the LMIC setting as compared to the high-income countries, where we do need to prioritize how we generate evidence, how we interpret it, and how we communicate to our patients. The ground reality, as you saw in some of the slides, is that what Carolyn presented, that for most of these patients, the disease is diagnosed at advanced stage. Cancer services are far and few, and most of the patients are forced to seek treatment in private care setting because the public hospitals are very crowded and have dismal infrastructure in many of these countries. Because there is no universal health coverage, there is largely out-of-pocket expenditure resulting in high financial toxicity. And what is challenging when we talk about these breakthrough innovation, that most of these patients are not able to even access the essential medicines for the cancer. And this was highlighted in one of the work which we did for, as part of the WHO AML group, the, Chris's favorite project of Desert Island. And this is just a secondary analysis from the Indian oncologists, what they perceived as essential and affordable for their patients. This was around 100-odd oncologists, almost half of them working exclusively in the private health care setting. What they prioritized for their patients, all 20 of those drugs were essential medicines. Almost 14 of them were conventional cytotoxic drugs, which were approved for several decades. And they reported almost 60% of them said that their patients experienced significant out-of-pocket expenditure while accessing cancer care and even getting these essential medicines. Drugs like rituximab, trastuzumab, which are true breakthrough, if they try to prescribe to their patients, they're going to experience catastrophic expenditure for taking care of their health, and which practically means going into poverty. India has done some important things over a period of time, and one of them is one of the largest health insurance schemes that is called Ayushman Bharat Pradhan Mantri Jan Arogya Yojana. Just to give you a perspective that it has, it covers a family of 4 with $6,000 for the year. And this has oncology packages too, health benefit packages, and it covers practically 40% of India's population. Now imagine we were to sit down and decide what constitutes the health benefit package for oncology, what drugs need to be included. And we need to be mindful of several of these challenges. If we recommend those drugs for health benefit packages through this scheme, what's going to happen? And one of the suggestions, one of the drugs, one of the interventions which has shown significant benefit in lung cancer, metastatic non-small cell lung cancer is pembrolizumab. There was a lot of recommendation to include this drug into the health benefit package, and therefore we did a quick and dirty adaptive health technology assessment. What we found that the drug pembrolizumab was costing almost 2 to 3 times higher as compared to some of the benchmarking countries. And if we were to include at the cost at which it was being supplied to the patients, it will need roughly around 3.7 billion Indian rupees, making many of the other important interventions out of the health benefit packages, which includes maternal and child health and some of the essential care. So that's the implication of including a drug, which is meaningful, but many times because of the pricing, it's very difficult to have all of that into the treatment or into the universal healthcare. What I'm going to do in next few slides is just to give you a scenario, and it's not n is equal to 1. This happens very commonly in our clinic, in many of our diseases which we handle. So this is a 55-year-old lady who hails from a rural area, comes to Tertiary Care Cancer Center with the diagnosis of locally advanced gallbladder cancer. She was performance status 1. There was just mild hyperbilirubinemia. Abdomen was 3.2. And therefore, the treating oncologist just referred to the international guidelines and the latest evidence. And what he found was this clinical trial, which basically suggested that addition of durvalumab to chemotherapy in advanced biliary tract cancer results in improvement in overall survival with a good hazard ratio of 0.8, which means 20% improvement in survival, almost doubling of 24-month overall survival rate with an ESMO MCBS score of 4 and NICE guidelines recommending these drugs. And therefore, as per that treating oncologist for this lady, this appears to be the best treatment. What it brings to that lady and her family is massive financial toxicity. Purchasing this drug on her own or by her family means $41,000 annual expenditure, considering that this drug would be going on for 12 months. And imagine, put this in context of the annual coverage from the insurance scheme of $6,000. Just to give you a background, most of the gallbladder cancer happens in individuals with low socioeconomic status. And if we are recommending this treatment nearly on the data which is available, we are forcing them into debt and, of course, the poverty. And most of the times, they won't be able to complete treatment. It will be treatment abandonment. And she will be in a situation where she will be in pain and do not have access to adequate pain management and palliative care back home. So these are the challenges, not thinking that these 12 months will be spent in the hospital, spent living in and around hospital, adding on to so much of time toxicity as well as healthcare resource utilization, whether it's truly meaningful or not. And that's what we need to do, when we talk about common sense oncology with respect to many of the low middle income countries, and we talk about the global health equity. And that's what CSO wants to do, as Chris showed in his slides, that access to basic human quality, good quality cancer care is a basic human right. No patient should be denied access to effective therapy or forced into financial catastrophe to access a meaningful cancer care. It's a patient and societal needs that should drive the cancer research and delivery of care. And just trying to put this perspective for this lady who's diagnosed with gallbladder cancer, whether you would offer a treatment which is going to push them into massive financial toxicity and time toxicity. Cancer treatment should be fairly priced for the context in which they are being used. Equity in access to high-quality cancer care should be prioritized as much as innovation and new treatment. So I think if we talk about the global health equity, if we talk about for patients from low middle income country, I think CSO has much more importance as compared to somebody who's in the high income country. That was my last slide. Thank you so much.
Thank you so much, Manju, for that. We all forget not just that, but the fact that she's going to lose her income for a whole year, weekly chemotherapy, and also the fact that her caregivers are also going to lose income for the whole year. It's something that we all forget about. So I would like to invite our next speaker, who is Dr. Julie Gralow, to talk about ASCO and CSO, Convergence and Collaboration. Thank you.
Great to see you all. I was not here for last year's meeting, but am excited to be here this year. And what Chris asked me to talk about is where there might be areas between ASCO, the American Society of Clinical Oncology, and Common Sense Oncology, where we converge and where we may collaborate. I have no disclosures. So as I thought about this talk, I reread the Lancet Oncology paper, the website for CSO. I know ASCO fairly well, being the chief medical officer. And I made this slide of what I believe is we have a shared vision. It starts with being patient-centered. We agree we want equity, access to care, quality care, value in care, evidence-based care, and patients should be our partners. This is ASCO's 5-year strategic plan that we just launched in 2023 with our mission, our vision, our core values of evidence, care, and impact. Our 5-year goals focus around access, removing barriers to high quality and equitable care and patient-centered research, profession, where we want to drive healthy clinical and research work environments that lead to fulfillment for our professionals, and knowledge. We want to be the trusted source for timely and high impact continuous learning. And in this year's strategic plan, we put equity, diversity, and inclusion and global impact across everything we do. ASCO does have a global commitment. We have that American in our name, but 40% of the attendees at our annual meeting and 1/3 of our membership are from outside the US. We have nearly 50,000 members in over 170 countries. We offered ASCO membership free in low and lower middle income countries a little over a year ago. And what happened there was Canada always was #2 in terms of our membership after the US. Now India is #2 and Canada is #3. And in order to, with all these international members now, in order to better engage and understand how we could adapt ASCO's programs, our projects to these regions and give them what they want and need, how we can adapt them, we formed regional councils with Asia Pacific starting in 2019, Latin America Regional Council in 2021, Sub-Saharan Africa in late 2022. We just kicked off our Central and Eastern European Regional Council, and just last month we started an India advisory group where we're going to learn what we can do in the region. ASCO's had a long commitment to high quality, equitable cancer care, and this, I'm not going to go through it all. This highlights our journey. I'll just point out, we developed our first ASCO clinical practice guidelines in 1994. We started our Quality Oncology Practice Initiative, or COPI, pilot in 2002. We started our quality training programs where teams come together and say, this is what we want to fix in our system, and you can do it over a short couple-day workshop or a 6-month-long project. And we've evolved our COPI program into what we now call ASCO Certified. We finished our pilot in the US, it's open to US sites, and we're about to launch an international pilot to see how relevant it is in other parts of the world. And this is what ASCO Certified is. So this is basically quality care based on now what we call our oncology medical home that we developed with the Community Oncology Alliance. So there are 7 pillars. They're all focused in the middle on the patient. So patient engagement is a pillar. Availability and access to care, another pillar. Evidence-based medicine, equitable and team-based care. Quality improvement, we include goals of care, palliative and end-of-life decisions, and then chemo safety. So there are standards that are built in to each of these 7. They're evidence-based standards. This provides a roadmap to high-quality care. And part of the process is that you undergo self-examination, ongoing assessment, and continuous quality improvement. ASCO back in 2020 came up with this statement on addressing the affordability of cancer drugs. We've already talked about how expensive cancer drugs are. It's a big problem in the US, not just in low and middle income countries. So we stated back in 2020 that value-based solutions should be patient-centered and evidence-driven in total alignment with CSO. Oncology professionals should be the ones who define optimal care and provide a framework to assess the comparative value of different treatment options from a clinical perspective. We do believe there should be a real and consistent relationship between the value of a drug and its cost, but physicians don't control the cost of drugs, but we do determine how we use them, and we are accountable for appropriate utilization. And that gets back to Common Sense Oncology's vision. We also have had a longstanding commitment to high quality, equitable cancer research. I oversee our ASCO Center for Research and Analytics, or CENTRA. Our board has approved what kind of research we can pursue. And basically, it should be research that ASCO is uniquely poised to address. We should not be competing with industry, the cooperative groups, or anyone else. We should fill knowledge gaps that are clinically meaningful. They are problems that are occurring regularly in clinic that are meaningful to patients and providers. We should employ our research methods and tools that are embraced by us, fit for purpose, and we should engage patients and their advocates in all aspects of the research process. We've done a lot of work on expanding eligibility criteria, decentralizing and making clinical trials patient-centric. We're trying to make trials accessible to everyone, and we partnered with the Association of Community Cancer Centers in a pilot looking at improving ethnic and racial diversity in clinical trials, which has two parts: a site self-assessment tool and then an implicit bias training called Just Ask. Because we have pretty good data that if a patient is eligible for a trial, and a lot of racial and ethnic minorities and other minority populations aren't eligible in the first place, but if they're eligible and they are offered, and we frequently make assumptions about, oh, they wouldn't want to be in the trial, they couldn't keep up with it, so we don't offer it. But if you go through that, they're eligible and you offer it, then a lot of our underserved populations accept at the same rate as our well-served populations. ASCO has one up and running clinical trial, another about to start. This is our TAPER trial, which stands for Targeted Agent and Profiling Utilization Registry. We basically take targeted agents that are approved for one indication and test them outside that indication. So you have to have, you have a tumor type, and then you find a genomic variant that's potentially actionable, and then you match it to a drug that's FDA approved, but not for that indication, that tumor type. And to date, we've tested 25 treatments, 85 different targets in 40 or more solid tumors. Now, I bring up this trial to show you we are a very pragmatic trial. Okay, this is meant to be real world accessible. We're very proud of the fact that our enrollment of Blacks and Hispanic, Latinx, and patients over 65 are much better than cooperative group trials, industry trials. We have a single master protocol and a central IRB, so we just modify the protocol each time we bring a new drug in. We have very broad eligibility criteria. We allow any validated genomic profiling test. The physician can choose what type of genomic testing, what drug dosing, what dose modifications. We supply the drug, they pick the dose, they modify it. We have limited data collection. We don't collect grade 1 and 2 toxicities, just what we need to be safe. We let the investigators assess response. You determine if there's progression, response, et cetera. It's IND exempt per the FDA. And while we do have data validation procedures, we don't do regular auditing and monitoring. It's pragmatic, it's real world, it's easy. Here's the next trial. When I came on board, I asked our research committee, what are things you're frustrated with that we need answers to that nobody else is doing? One thing they said was, for the drugs already approved, the oral drugs in particular, that we know are approved at way too high a dose because they were built on maximum tolerated dose, but they're targeted agents. We would like to better understand if we can give lower doses. And then the other thing, and I haven't quite gotten a trial up and going for this yet, is we want to look at the comparability of immune checkpoint inhibitors and their biomarkers. I am working on that one. But this trial is now funded. It's IRB approved. I just got the IND exemption from the FDA as I was flying in last night. It is basically a trial of older patients. Have to be careful how I define that because now I'm in this age group, 65 or older, who have hormone receptor positive, HER2 negative metastatic breast cancer. And in the metastatic setting, it would be the first use of a CDK4/6 inhibitor along with endocrine therapy, at least its first use in the metastatic setting. So what we're doing here is this is an age group where patients frequently aren't even started on the CDK4/6 inhibitor because of concerns about toxicity, or they drop off of it very quickly because the high doses are just too much between neutropenia and fatigue. So we are looking at a randomization between starting at the FDA-approved dose and then de-escalating as not tolerated versus starting at a low dose and then titrating if tolerated. And what we're hypothesizing is that by titrating the dose, we'll get to the long-term dose. Patients live years and years on these therapies. We'll get to the long-term dose. They'll be able to tolerate treatment better, stay on treatment longer, and derive more benefit from the treatment. And the primary objective is time to discontinuation of the CDK4/6 inhibitor. And so we will launch this by the end of the year. And we got $11 million in funding from our Patient-Centered Outcomes Research Institute that was created with the Affordable Care Act. So they believe in this too, that it's patient-centered, it's answering an important question. We just published this paper, position statement on global equity in clinical trials. I have a quote from our moderator here, Verna, that says, increasing global clinical trial participation is crucial to helping us better understand the nuances of cancer care in different populations. And we really are committed to helping our colleagues around the world and doing research that's relevant to their country, to their region. And, you know, we are told all the time, we have training in how to do research and how to do trials. We don't have opportunity. We can't compete for an NIH grant, you know, and we don't get scored as well because we're not answering a question that the NIH grant reviewers think is important, but it's really important in our country. So with our regional councils that I showed you, one of the first things that happened was the Latin America Regional Council said, we want access to research funding, and we want to say what's the important research. So we went out to industry. Pfizer bit for each of our 3 regional councils that we started this in. They've given us over $1 million. They've handed the money over to our Conquer Cancer grants management, and they gave it to the regional council and said, you write the request for proposals. You promote the grant, you review the grants and oversee it. So in 2023, we announced this in Latin America. We got 61 applications from 11 countries. We were able to award 9. In Asia Pacific, the applications are under review. They just reviewed them in Borneo last week, and 10 to 12 will be awarded. And then we announced it in Sub-Saharan Africa. And, you know, seriously, 2 days before the deadline, we didn't have any. And then within 2 days, we had 185 letters of intent. And now we're going to have to narrow that down and invite the letters of intent back. But basically, there's a lot of interest and a lot of need for this is the point. So last part, I'll just say we're also committed to high quality evidence-based education. This is Lynn Schuchter, our ASCO president. The theme of her annual meeting is the art and science of cancer care from comfort to cure. This is the first ASCO president to come to an aortic meeting. She came to Senegal because she said, I want to understand the global impact. And Chris has already shown you this. She heard Chris speak at the aortic meeting and used his guidelines, modified a bit, to give to our plenary discussants and say, this is how you're going to discuss these studies. And also Common Sense Oncology is going to feature prominently in a special ed session that ASCO and the European Cancer Organization are doing jointly. And the session's called Common Sense Oncology, Equity, Value, and Outcomes That Matter. So I gave a talk a month or 2 ago at Queen's, I was invited by Bishal and Chris. There was a lot of talk about ice fishing. I came totally prepared. There was no ice to be seen. And Chris said, but after you come, you're going to be able to do a talk on ice fishing in Ontario and common sense oncology. So we just had our ASCO strategic planning retreat on AI and how we're going to use it in oncology. I met Claude, which is an AI tool. And so I said, hey, Claude, what should I include in a talk on ice fishing in Ontario and common sense oncology? I'll save this for you to read later, but basically he said, you can draw on relationships in these areas: perseverance of patience, finding moments of peace, appreciation for nature, strategy and technique, and community. So basically he said I should talk about the quietude of ice fishing and the mental, emotional fortitude needed when confronting cancer. And I will leave you with that. Thank you very much.
So thank you very much, Julie. That was exciting. And I also like to talk about the Lancet Commission on Women, Power and Cancer that was just launched. And we have a lot of our commissioners here, and there are a lot of patient stories. Basically, what it's telling us that we are not listening to the patients, and we are not taking consideration their journeys into delivering cancer care across the cancer continuum. So I'll urge you all to read that. And last but not the least is Dr. David Collingridge, Editor-in-Chief of the Lancet Oncology, to talk about leveraging change. Thank you very much.
Well, good afternoon, everyone. Thank you, Verna, for the introduction. It's quite an unenviable task to follow 3 magnificent talks. So this is going to be tricky. So why am I here? Chris asked me to talk about leveraging change. And what do we mean by this? Well, this movement, Common Sense Oncology, I think it's going to be judged on 2 things: the academic rigor of what we achieve, but how we transform that into action. And so Chris asked me to look through some of the occasions through the eyes of Lancet Oncology where we've done transformative things, and whether there's any learnings that we could all take away from that. And I think I'll start with a couple of quotes, which always sort of come to mind in these sort of situations. Albert Einstein said, the measure of intelligence is the ability to change. And Mother Teresa more pragmatically said, I alone cannot change the world, but I can cast a stone across the waters to create new ripples. I think they're both very apt in where we are today. So I've pulled together 7 learnings from the Lancet Oncology's experiences in health activism and health advocacy over the years. Learning number 1, publishing the paper is not the end game. That's not what we're here for. We're not here to publish a paper. It's what you do with that research or that information. And this shows Verna was part of this, this commission. This is our Commission on Cancer Control in Sub-Saharan Africa. Obviously, publishing the booklet was fantastic, but the booklet wasn't the end of the game. This was the start, and this was the launch event that we held in Accra, in Ghana, where we met ministers of health, First Lady of Ghana, former president. We had press conferences. We met the King of Kumasi. It was quite an event over a period of a week. We did radio interviews, lots of news coverage, press coverage, and that was just to get the ball rolling. So I think this is an important message. Publishing a paper, you've got to use it to make some change. You can't just assume that it will osmotically get into people's minds. But of course, then you carry on. That event in Accra was just the start. Since then, we've had multiple events where we continue to push this message. We had an event in Dar es Salaam, an event in Abuja. We've had follow-up events in the Tanzanian embassy in the US. And we keep pushing. And this has actually now led to another commission. And this is the Lancet Oncology Commission on the Commonwealth, of which many African countries are part. And this was a kick-off event, very grand state occasion at Marlborough House in London at the Commonwealth Secretariat. And And this commission will play out over the next 2 to 3 years, where we look at how can countries work together for the greater good. Collaboration is key. And that's going to be a real driving theme in this commission. So publishing isn't the end of the story. A second learning, make the most of your network. We've seen that a lot today. This is another one of our commissions looking at medical imaging. You see all the partners we had involved in this commission. All of those partners, or a good number of these societies and partners, have gone on to promote the key findings from that commission and taken them forward. So again, it's lean on those partnerships. And this is exemplified here that sometimes there's one or two key individuals. And this was our Cancer Control in Small Island Nations series, looking at cancer control in the Pacific Islands and also in the Caribbean. Very unique situations in those island states. As you can see here, we had the privilege to launch this at the Pacific Health Ministers meeting. Now, how did we get into that meeting? Well, one, we had Dice Fati at the back of the room, who's absolutely magnificent with the connections. But also there are key people in this kickoff meeting, and one particular guy who's part of the Pacific community, and he opened the door to everything. And so it's about that serendipity of meeting the right person at the right moment in time. And be ready for that elevator speech when you get in those situations that you suddenly end up in a room with someone like that. You've got to have something to say. And these are just some occasions where different politicians, through bizarre circumstances, I end up standing next to. What are you going to say? Use those moments to advocate for change. I think another concept is don't burn your bridges. You know, I'm sure we've all been in situations where you think, I don't want to see that person ever again. But actually, many people are very helpful to keep them as good friends into the future. And I give this as an example, not someone I burnt my bridges with, but just an example of someone who's been a great friend of mine over a very long period of time. That's the lady sitting to the next to me, Pat Price, Professor Pat Price. She was my boss when I was a postdoc. Now we jump forward 20 years plus, and I'm working very closely with her on the National Cancer Plan in the UK. Our government, in its wisdom, has decided that England doesn't need a cancer plan. Complete opposite direction to the rest of the universe. So we brought together a group of people towards the end of last year to design a blueprint for a cancer plan in the hope that the next government will actually use that blueprint. So we've been lobbying through the House of Commons, the House of Lords, and other political channels in the UK, and Pat Price has been absolutely magnificent opening doors for us. Create your own opportunities. So this is an example of an ERTC meeting, CSO meeting. This was an event set up a number of years ago, back in 2018, to look at standardizing statistical analyses for quality of life, because it's a bit of a wild west. And this was a great event. Nice paper came out of it with some standardized guidelines. But there's an opportunity here of meeting regulators. And I met, for the first time there, Paul Klutz from the FDA. We had some fantastic conversations about how the regulators should actually be involved in this conversation. And since then, that has led to a slew of FDA papers in the Lancet Oncology. So sometimes, you know, opportunities present themselves and you should make the most of them. The fifth learning is quid pro quo. We all work with people who help us enormously, and sometimes you have to give back. And it's important to give back. And this is an example here. This was in Davos earlier this year at the World Economic Forum. We've worked at the Lancet Oncology with the International Atomic Energy Agency for a very long time. They've supported a number of commissions and other projects with us. But I had a frantic phone call from them between Christmas and New Year saying, we've got a slot at Davos. Our DG is going to be there. Will you interview him and run a panel discussion? We've got a week to make this happen. And this is between Christmas and New Year. Well, we made it happen somehow. And it was a fabulous session. but that's quid pro quo. They've helped me, I've helped them. And I think that's important. It keeps the relationships going into the future. The sixth, learning, I would say, is persistence. Play the long game. Coming back to the cancer plan. I wrote an editorial in 2007 entitled, "Does the UK really have an effective cancer plan?" That led to a phone call from the frantic phone call from the cancer director, Prof. Mike Richards, saying, "How could you write this stuff?" And I said, "Quite easily, Mike," for various reasons. 17 years later, we're still banging the same drum. In fact, we've gone backwards because now we don't have cancer. So stick with it. Don't give up. And this is also another example of how you shouldn't give up and how these things should evolve over time. In 2017, we had the opportunity to publish our first commission working with the White House on the moonshot. We published that, we had a launch event, actually, the UN headquarters in New York. Jump forward 5 years, here we are in Bethesda at the NCI, kicking off the second commission on the moonshot, which is totally focused on workforce in Latin America and Africa. And the final learning, say yes more than no. It's really easy to say no. You can always find a reason not to do something, but sometimes you just have to say yes and worry about the consequences of that later. That's caveated, that comment. But this is a typical example. This is Davos 2022. We'd just done the launch of the cancer control meeting in sub-Saharan Africa. I was in an airport with one of the commissioners. We get a phone call. Would the Lancet Oncology like to run a session at Davos on sub-Saharan Africa? I said, we have never been to the World Economic Forum. Why would the journal go to the World Economic Forum? We're not economists. I was like, no, but those guys pay for everything you do. The billionaires in the room, the millionaires, the philanthropists. Shouldn't a medical journal be there? So I said yes, and then worried about the consequences of that later. This led to this panel discussion in Davos. Very unusual event. The room was about 40 people, all billionaires. Very unusual audience, but incredible, because these are the people funding new hospital builds in Saudi Arabia and all over the world, Ethiopia and so on. So we were able to get our message across about the importance of that. So I think I'll just wrap up very quickly here and say that in-person events and meetings rather than virtual are far better at networking, at least initially. You should certainly make use and make the most of serendipity. And I think academic medicine that we're all involved in here, it can provide a platform for change. It can be more than just research and debate. It can be political. You know, organized medicine, equity, equality, the right to health, these are all political issues. We should be advocating for change, and we should certainly use this platform for health activism. I think at that point I'll stop. Thank you.
Thank you very much. I invite my audience. Brian, can you please do that? So we are ready for questions from the audience. Unfortunately, we can't take questions online, but if you have any questions, we'll be glad to hear them. We know India has a lot of experience with poverty and managing cancer care. Most of us from low to middle income countries learn a lot from experiences from India. So I'd like my first question to go to Manju on how she thinks we can apply CSO in India. And I put you on the spot, but I think you're the best person to tell us this.
Happy to be there. And so I think everything, whatever we are doing in terms of all the three aspects, whether we talk about evidence generation, interpretation, communication. And I would begin with, a lot which can be done in the evidence interpretation, making the oncologist and the people on the ground aware of what the clinical trials are, what the papers are, and how to apply that into the clinical practice. Because They are the ones who are recommending treatments. Even though, till such time we say that we have clinical trials addressing our local problem, which are also equally a good, thing where CSO principles can be applied. Till then, I think the interpretation of the evidence, taking it into the clinic, I think that would be the first and probably the biggest impact which we can make. And of course, bringing in the patients, because that's one thing which is very important, that we need to make patients partnering into what we are doing. And advocating this aspect into our clinical practice is equally important. So I think all three things are very, very relevant for India.
Thank you. Any more questions?
I'd like to ask two questions. Firstly, for David, are the medical journals or the medical journals of oncology taking any sort of stand or developing policies so that the medical writers that are funded by the sponsors and essentially largely ghost writers, because the name we've got here on the authorship list and the degree of participation in actual writing of the first author is often very dubious. That's the first question. And then the second question is for Julie. Julie, I recently reviewed the ASCO guidelines, the new ASCO, the revised ASCO guidelines for metastatic colorectal cancer. And I was really pleased to see the last section talked about the economic consequences. However, going back to Sandra's talk, in terms of third-line therapy, it advocated for the use of this very expensive agent, which has lots of toxicity and very minimal impact on either progression-free survival or overall survival as the treatment of choice. And to what degree is there oversight in the development of guidelines to look at the issue of marginal medicine and really poor decision in almost an appropriate practice in late-line therapies, because the guidelines are still filled with these robust recommendations with evidence scores of 1, because it's based on a randomized clinical study, with really a magnitude of benefit, which on an ESMO scale is 1 on a scale of 5.
Hi, Nathan. Yeah, really good question about the use of medical communications companies. Nearly all trials use medcoms by all pharmaceutical companies, biotech companies. It's a systemic issue. So for a single journal or single journal group to go in its own way off and outlaw that or not consider papers, we'd end up not publishing any trials. And I think then there's a moral dilemma, because all these patients have gone through a trial in good faith, and for us to not publish that evidence, all we can do as editors is ensure that what's being published is as honest and transparent as possible and manage those medcoms. But equally, we as a publishing community need to be working more collectively, perhaps through ICJME or some other organisation, where we can start advocating for the change in the culture in which trials are written.
And I would say having an editorial that goes along with it that's totally unconflicted, it can help balance. So I don't know the details of the third-line colorectal, metastatic colorectal recommendation, but I think it's very fair. Call us out. I mean, we work so hard at getting representation across our guidelines groups and non-conflicted, and there's all these rules about, who can have funding and who has to be pure and what percentage and all. But I mean, we still do. We make mistakes. We don't point out the value. We try to refer so that everybody can look at what the actual trial was. But call us out. I mean, the guidelines that ASCO puts out are really meant, for a US or a high income audience too. I will point out, we're not perfect and we want feedback.
Thank you, Julie. I'm ordered to stop. I know you had 2 more questions, but I have to obey the rules, and so I have to do them.
Thank you very much to all the panelists and the moderator. It's very exciting to see all major stakeholders from organizations, from publishing, from patients, from clinical trial community, everyone here together, so that I think this is the venue where we can discuss about these changes happening.